so
right.
strong.
Continue every time we have a great ground rounds, the Bucks win. So that's it's gonna be a great ground rounds, and if the Bucks don't do their thing, that's on them. It's not on you. So, all right. So I'm gonna go ahead and get started. So welcome to the Roy Benke Department of Internal Medicine Grand Rounds. We have a great speaker for our second talk of the academic year, Dr. Qureshi. So Dr. Qureshi is one of our own, trained here in the USF Department of Pulmonary, Critical Care, and Sleep Medicine, and joined as an assistant professor in the Division of Pulmonary, Critical Care, and Sleep Medicine, what seems like a while because he's done so much, but just a few years ago. Dr. Qureshi is the Associate Program Director for the Pulmonary Critical Care and Sleep Medicine Fellowship, and also the Associate Program Director for Advanced Lung Disease and the Lung Transplant Fellowship. So he is, speaking of, as we were talking right before this about being an advocate for fellows and residents, having his major leadership capabilities in not only one fellowship, but two fellowships really adds to the great dimensions of him as a leader. He's also the director of the ECMO service line and program at Tampa General Hospital. Dr. Qureshi has been instrumental in the gold level designation as a Center of Excellence for the Extracorporeal Life Support Program, which is known as ECLS, that Tampa General has received. With all of these roles, he has translated this into amazing scholarly activity. He has presented at the American Thoracic Society in 2023, and also International Society of Heart and Lung Transplant Conferences in Denver 2023, and in Prague in 2024. He is the the PI of numerous clinical trials and co-PI of numerous clinical trials in this case. So he's just absolutely been fantastic. I wanted to impart that Dr. Mosley couldn't be here today for added comments, but wanted to really touch upon the incredible program that we have and what he has been and what Dr. Qureshi has been able to do to add to that Tampa General USF partnership. This is an incredibly important program as we move forward, and Dr. Mosley wanted to send his recognition of the great work for everybody here, and he will be watching this later. So Dr. Qureshi, please move forward with a wonderful presentation. You all are going to enjoy this.
Thank you very much. That was awesome intro by Dr. Lozama, and I'm thankful and humbled by it. I'll try to keep up with the pace of Dr. Lozama's kickoff last this grand round. So hopefully we'll do. So that's my intro. Like Dr. Lozama just mentioned, my role over here at TGH under this. Okay, these are my disclosures. All clips and pics that that you would be able to see are appropriately consented and voluntarily permitted by the patients. Just a brief outline. I know it looks a busy slide, and so just like brief history, some concepts, some global trends and utilizations of ECMOs, and what really indications and contraindications have evolved into. Other than that, we'll talk about also registry and the ECMO program at TGH, specifically the governance structure and quality outcomes at Tampa General, as the Tampa General staff and USF faculty serves, because this is very important to reflect on. And then we'll get into the case reviews. And unfortunately, the last part would be my part 2 in January that I would be continuing as my part 2 for grand rounds, hopefully, after this, if Dr. Lozama allows. So let's get into some of the history of ECLS. And this is, as to be really honest, how it looks like, this is exactly the first thing that comes into mind of patient families, and for the most part, physician providers before the pandemic, I would say, or people who were not exposed to CTICU or were in healthcare kind of subspecialty that was exposed to, that this is literally how it would be. ECMO machine, a big gigantic, just a big gigantic vent. So how it started all was through Dr. Gibbon, and this was in 1937. And the first human OR bypass that was done in 1953. I would highlight that in the interim period, there was so much that was research and lab um, research were going on into membranes and lung membranes, perfusions, and but they were animal models. But there was a lot of research that was being developed. But in essence, I would, and my slide would actually give you depict a quick timeline. But I wanted to say that when this was really engaged into being interaction with healthcare was the 53. That was the first time that it was used. Now, a quick timeline for, and like I mentioned, ECMO is one of the evolutions. So if I say AI is the new be in town or the new talk, right? I think that after pandemic, this was kind of a kickoff for ECMO that changed a lot of thought processes or how they could be, or in healthcare innovation or crisis management, this kind of gave it a good kickoff. And if you see, after 1953, early 1970s was actually the first adult ECMO that was done in ARDS trauma was in 1971, if I'm not wrong. And that was our first adult ECMO. And after that, it was a cardiac surgery for transposition of great vessels. If I'm not wrong, that was done in 72 or California. And then a newborn was done for a meconium aspiration was in 1975. These are just those key fundamentals where the kickoff started. But if you see, could everybody see my arrow?
Yes.
Okay. So if you see, like, from 19, all on the left side, these are like timelines in 1970s, how much it was kind of evolving. And still and it was not until 1980s. And to be really honest, one of the pioneers right now of the ELSO, Dr. Bartlett, he was the one who was, and the founding members too, who was very involved and engaged to start off with. And of all 70s, this was an evolution, a lot of clinical trials. I could just start naming from late 79, from starting from the NIH ARDS to RCTs, Caesar trials in 2009. This is how this has evolved from 70s to 80s and here 2009. This is where the your influenza or H1N1 pandemic, and it just keeps on evolving. But I do want to say that part of this evolution or change of practice was because there was a lot of modifications, advances in the mechanics, devices, and uses in itself. So it's not only the healthcare or the practices, but the mechanics and how it was used or how it was utilized, and the scope of practices. The ELSO Foundation is the 1989 when it actually started, is actually a registry that we'll talk about. Now, when I talk about, when we talk about trials, there's a lot of trials that went on for ECMO, and now I do think that I could tell you that it is one of those where you go to these conferences, it's a big component on each. And it doesn't really incorporate just respiratory or cardiac. A lot of service lines or patient team subspecialties are um, engaged into this kind of support. Now, this specific NIH trial, I mentioned it just because this is one of those critiques that you could say, how not to do a clinical trial, and that was stopped. The work on ECMO for ARDS patients for approximately 2 decades. And this was just because it was, I think, if I'm not wrong, there's 3 center that were experienced. They were very limited into the capacity of, like I said, we know arterial access only. So not like a VV versus VA, not randomized appropriately or triage. And that is why the survival was only 10%. And that kind of put it to the shelf. And the hesitance to use or utilize this was like what we lost, like approximately 2 decades, like I mentioned. Some basics, just so that I'm pretty sure that everyone is aware, but in general, this is this is really how I see ECMO. This is just a device that's fancy or an upscale to a ventilator, but it is a membrane actually oxygenation that supports native lung and plus minus heart function. This is, I don't think so that I could have a very simplistic other than this, that this ECMO, that's your circuit, because you have a pump and then you have a membrane that has an oxygenator and helps you take care or flush. Initially, it was called a blender because it used to blend, take off, remove the CO2, and give some oxygenation. And this is as simple as it gets, but this is where how it mechanics work. Blood drain from the venous side passes through a pump, that's this, an oxygenator, and then blood return to venous or the arterial side, depending on the patient's need. Again, I just like to re-emphasize on this because I know there are fellows as well and residents too, and I always tell them during rounds two, trust me, this is just mechanics. I know Dr. Sharma, he was over here, I think when I was in my second and third year, and he had a very famous quote of mentioning that, hey, trust me, it is the simple things that matter. It's either the cannulation, either the position of the cannula or the circuit, and not, there are zebras that happen, but most of the time it's the simple things. So I just want to emphasize, for example, VV ECMO, again, it's veno-venous drainage from the IVC or the superior vena cava, and again, pump and oxygenator we talked about, and returning back to the venous circuit that the veno-venous, like the right atrium. And this is where the heart and lung see full cardiac output because you are not bypassing anything. You are literally just oxygenating and putting it back into the system. Lung supported, heart not supported at all, because these are the patients that you think that predominantly benefit from the lungs or are the lung as a driver. Now, on the other side, the veno-arterial side, and I'm sorry, a little bit of the pointers might be off. I am trying to learn with the graphics too, thanks to YouTube. But from the veno-arterial ECMOs, drainage from the right atrium, again, from the venous side, the drainage would be always the venous side, pump and oxygenator. As I said, this is as basic that I try to, because I'm a very simple person to, so I like to focus on simple ways how to connect with it and then return it to the arterial system. In this way, it would be a distal aorta, or sometimes it's very fancy hybrid configurations, but the arterial system would be the return. In this scenario, where you have, it's a heart and lung, where you see part of cardiac output and lungs are supported and heart is supported. Now, going forward, just like I mentioned, this is a very fancy version, and I've tried to reference in some articles. If anybody has interest on these, they are very simplistic. How to curtailed down into different configurations that look very fancy. Again, like I said, these are venous ECMO, like from a femoral to an internal jugular, and or versus this uh, being double lumen. This is a fancy catheter that has, if you look at the uh, catheter, it has jets. It has one is two ports. They drain from the right from the SVC and the IVC, same single lumen catheter, but there is a third port which is in the middle that returns it toward the right atrium jet to oxygenate. These are all these, like I mentioned, changes or modifications made to the circuit and to make it simple. Again, veno-arterial, this is as like we mentioned, blood is extracted. Again, simple. And you would see in the subsequent slides that, to be really honest, all that has happened is evolving how to simplify it. This slide looks super busy, I admit, but there's a reason why I have it, and I will tell you subsequent slides again. These papers are positional papers. These are consensus, those documents that big centers have had into revising or kind of reviewing what really would trigger the indications and contraindications. Because putting somebody on ECMO is as challenging as taking them off ECMO or having a successful run or to help the patient. Again, from indications, like we have so many variable scores for whether it is PE, whether it is any like AFib, you would have scores for every health condition. This is a similar pattern. A lot of individuals or a lot of facilities, they use different parameters to gauge, but at the end of the day, these are to support your decision making or to kind of give you an idea which way to turn. Now, coming on from the VA ECMO perspective, if you see acute MI, decompensated CHF, these myocarditis or bridge to VAD or transplant. Transplant is always when someone thinks of ECMO, it is I think of is most of the times transplant is not off the list. Why? Because you should keep in mind that if you are putting somebody on ECMO, either you know really that it is reversible, or you have had these discussions that what is at the same time when you're thinking about putting them on, what is your exit strategy? Because as much as I like the machine, it is in a beast and it has complications on its own. And again mentioning, I'm gonna drift through these faster. Why? Because I really want to get to the more interesting part of cases, but I'm not trying to rush, but I'm trying to just emphasize on, if you look at these different papers that have been published every now and then from 2019 or 2021, every now and then you will see how simplified they would have been getting. Again, advanced malignancy, a lot of people would think leukemia, right? This is a malignancy. Again, the dynamics or thinking about it. Oh, is it an ALL? It is an AML. Is it sub or lymphoma? It is amenable to recovery or remission. These are all these things that you talk about before or when these triggers for ECMO come in play. And again, these papers and everything are there to reference to. But I'm just trying to skim through just to give a bigger perspective. Now, the question always comes when it is ECMO is, like I mentioned, rescue support for a reversible or a recovery cause, or is it a bridge to decision versus bridge to advanced therapy? And advanced therapy could be anything like a mechanical device for a heart, or this is where bridge to decision, whether you are trying to do something just to stabilize in order to see what is driving the decline or the driving the patient's decompensation. If you see at the end, we saw so much of complicated or those complex charts, but if you see now indications as far as reversible cause, temporary heart or lung support, you keep in mind And then lung, simply it's refractory hypoxemia or a refractory hypercapnia. For heart, it's a refractory cardiogenic shock, not able to support on pressors, or refractory cardiac arrest as a ECLS rescue therapy, which a lot of big centers are now focusing on. Now, defined end goal. Again, would like to emphasize when triggers or these consults are made, one thing other than just doing them or thinking about is what is going to be the exit strategy. Same thing goes over here for contraindications. Like I said, they have every now and then tried to simplify and streamline that this needs to be a multidisciplinary or a discussion between teams. Let's shift our gears towards something that is more centralized, and that is ELSO. So ELSO registry is one of that was established in 1989. It really fosters a rich collaboration among centers that perform ECLS, uh, and now it is a worldwide organization. Uh, any Everybody that has any influence or any stake in ECMO management is part of that or some way connected to that organization, whether it's surgeons, neonatologists, nurses, perfusionists, RTs, even the biomedical engineers or these innovative companies now, because this is what it is. It is a platform where, and this is a true reflection of how ECMO runs. It is a multidisciplinary, or I should say, a transdisciplinary approach now. Now, just looking at trends, if you see these trends have been not only like, a lot of yes, there was a spike that was in 2021, but as we will see the data now, and especially we being the transplant center and other big centers or other big even trauma centers or these, they have numbers still pursuing or they're keeping up with their volumes um, even after pandemic. So these are how the ELSO registries they go across, and every year in October they have a report that is published throughout. We are expecting to have the 2024 report soon. For if you look at the last 5 years for North America region only, it is from a survival standpoint, from a pulmonary. So we do not have a pediatric and neonatal, but we have done pediatric whenever it is needed. But we are looking into growing that specialty too. But if you look over here from an adult standpoint, 52% survival for the adult in all, and 66 for pulmonary, and 50% for cardiac. For ECPR, as we are aware of, it is a rescue therapy and it is a kind of a desire that you are trying to as a last resort. This is a true reflection on why the increase. It answered a lot of questions, what we just talked about. This is the 1971 trauma first adult ECMO patient that was done successfully, had a trauma ARDS related. Just by looking at it, I know I'm going to trip over something in that room. I hope, this is so complex, right? And now from this whole circuits, we have gone through this. This is the cardio health circuit, and these are where we are growing. To be honest, it is more of a provider experience wise, why the increase is a more provider experience, technological advances like cannulation, circulation, pumps, and advances, better patient selection, and like I said, transdisciplinary approach. This video, I'll share the other slides too, who are better predictors, just because I want to come to cases. Again, and also registry of for TGH trends. Like I said, it was where we were or survived. It's like 55% was our national North American. If you recall, again, we are 58% of this, but right now, even if you look at for adult, our total overall outcomes by center. This is TGH right over here, data. So that's like 47%, 34. We have improved and we are below our national, like, we are doing well. And other slides, I'll have some real data for 2024 to actually reflect on too. Like Dr. Lazama said, to be really honest, TGH has moved towards a service line structure for it, and not only for the cost that it feels, but the utilization of ECMO across service lines. And that's not limited to any particular one specialty. Yes, there are key that are transplant, heart and vascular, critical care. However, we have seen a lot of trauma patients and our trauma team collaborations, numbers, oncology as well, and others that kind of benefit or have that support and access. And that is what we would like to highlight, that it is across TGH, that we would like to say that the USF teams and TGH teams, they have the support. This is the governance structure to be, it's led by an ECMO steering committee that really has a core that has a cardiologist interventional, a MCS director, CTICU director, myself, and surgeon representation, as well as perfusion and nursing lead, as well as quality team members, not to mention APP representation too. This core meets a monthly basis and has an executive oversight of a TGH leadership that meets on a quarterly basis. This is our timeline. Yes, we are proud of our team, what we have achieved, and this is all from all the collaboration across Tampa General and USF teams. We were just announced at Gold Center of Excellence for the first time ever that we have filed an applied for, and this was our July 15th that we were announced. It goes into effect for 3 years. However, we will aim for platinum next year, because we just want the best. Right now, I will these slides would be there available so we can go through. There are a lot of we have achieved, a lot of we are working on for a quality outcome perspective and patient care. Uh, I do want to emphasize we are having our first ECMO symposium planning with Camel collaboration that will be on an annual basis. ECMO market share. I do want to take some pride in and say that among the statewide, not having a dedicated unit compared to Advent Health, Orlando, uh, we do, we have grown every year. If you see 2021, 22, 23, and kind of in the region statewide, we are second. I would give a number, and that is we are, I think, 4 or 5 ECMO runs behind for 2023. Let's see what the numbers look like this. But in the 15 county all market, we are the leader for the ECMO at this time. So this is the actual Arbometrics data that is taken from ELSO. The blue is Tampa General Hospital. The green is your national ELSO all. And if you look at it from this perspective as well, mortality rate 35, we are below national average, which means we are doing great. Yes, ECPR, we always have to take it with a grain of salt. It is going to be a rescue therapy, and that's the last resort. If you look at this mortality ranking slide from 2021, like I said, this is a lot of math and calculations, but simple. This red never appeals me or doesn't look nice. But if you look from 2021 to 2023, all inclusive, our ranking and our all mortality has improved significantly from the ratio or our volumes too. And it's not like we are doing less numbers. We have grown, but our quality has improved. I'll rush through these slides again. This tells you that the variation, this is our vision data at TGH, how from 2021, how we have kind of with closed CTICU and everything, have engaged into a universal practice across TGH and with these quality outcomes. This is ECMO runtime. Again, these are the quality ECMO quality metrics. Like you see the ratio and percentile I just mentioned. I'm not trying to rush, but this is the real factor because honestly, this is at the end of the day, I would like to reflect on these cases. So let's go through the case one. I hope if nobody has questions now, I'll take questions at the end if any. I don't see any hands.
Yeah,
So
go for it. Let's go to the cases and then we'll take questions at the end. I think that's a great strategy.
awesome. So 40-year-old male with no significant past medical history, COVID positive, seventh day intubated, outside hospital, felt short of breath. Levo pressors, tidal volumes, FiO2 of 100%, PEEP of 18, respiratory rate of 34. That's your gas, paralyzed, sedated, Flowland, prone, optimized as per your odds net. But again, I would like to emphasize odds net was delivered when low tidal volume and high PEEP was one of the factors, but it is no longer that case. And we are trying to drift away and successfully are now intensive with a closed model. They do take driving pressures as more of a driver. Now, the referral request for transfer to TGH for ECMO support. Now, unclear logistics or transport for referring support and everything, and this was initial in the COVID times. There are a lot of variables that you don't know about these patients, like the BMI. Again, like I mentioned, contraindications, indications. There, but the crunch time is they call you when it is right at that crunch, and you have to make the decisions. Of course, ECMO day zero on arrival at TGH, and this is their first chest X-ray and the first gases. The PCO2 is your six. That's the right number, by the way. PCO2 is 63, not the other way around, and PO2 is 38. However, the lactate is normal. And we have, and this is what I always say, there is no condition, and we all troubleshoot for that hypoxia. But if the lactate continues to be normal, no hypoxia or hypoperfusion, if not there, you should you should have a lactate if the patient is truly hypoxemic or hypoperfusing. We did echoes, we did lactate. Again, these are the settings that you would put on rest settings. But then again, if you drop the PEEP too fast, there's de-recruitment. But that was too high of a PEEP too. So this is the day zero. And then this is on day one. This is the first CT scan. I can hardly see other than the solid component or rock part of it. And we continued to just let it rest. And lactate was normal. It was lung protective standard. If you see on day one, we did come down to PEEP of 10, rate of 10. These are lung protective strategies. And then you just see the compliance. And we just were making sure we are giving the support. If you look from the 13th, being this on the right, you these all these PO2s, these are the PO2s, like I mentioned, it's not reverse, it's 38. The PO2s start getting better. Now, the PCO2s, yes, they are high, but then again, we are diuresing the patient. We are taking some volume off, the bicarb is driving. There are a lot of factors, but at least now we are seeing that there is the PO2 trend keep moving up and the O2 sats from 48, which was hard to tell a nurse to please just relax, nothing is wrong. But it was right. Everybody used to do their due diligence, check off all the points, and then let it give some time. Day two, if you see, still nothing that you see from an air bronchogram or that standpoint, CRT was initiated because we were aggressively diuresing. However, the PO2s continue to improve, and these were our diuresis that was done. And if you see over a period in time, it was negative, just like between we were removing 2 to 3 liters a day. That is all what we were doing at that point in time for that patient. On ECMO, day 3 and 4, finally we start seeing some lung parenchyma, some maybe, but definitely we see that there is much. These are the first time that we have seen SATs of 80s. So the patient gets tracheostomy, a negative 11 liters just day 3. No pressure needs, weaned off inhaled NO. These are all kind of your reassuring signs that there is some hope. This is your day 8. Sweep is being weaned as now you see the compliance is better. You can see some lung parenchyma. Of course, this is a long haul that the patients are into. But on day 14, the patients get decannulated. This was the patient's this was the patient that was the day when he got decannulated. And sorry, so we didn't do anything other than regular bronching and diuresing the patient and just giving it some time. Case 2, 34-year-old Haitian, presented at outside hospital, intubated, admission, and delivered 35 weeks. Was on conventional medical management for ARDS, had a BMI of 48. On those settings, plateau pressure 33 and or 44, I should say, 100% on vent. We get a call saying, hey, we have a patient, we need to transfer, we do not have capacity to manage. And as TGH and USF faculty members, we always try to help and assist these centers who actually call us for help. So this was something that was discussed with the leadership before we accept this patient because this was out of norm, right? 48, it's morbidly obese. You think, okay, what is going to be the exit strategy? This is a pregnant female who just delivered, and we accepted the patient. And discussions with, like I said, it was VV ECMO team, discussions were done, CT surgery. We actually cannulate at outside hospital and brought her to TGH. This was her first guess, vent settings. Again, she had a postpartum period too, a lot of bleeding, hemodynamics. They all play in a role. ECMO support day 10, transfer to 7A for rehab and vent wean, discharge 1 month TGH course. We sent her back to the hospital that referred. We did not do anything other than giving her the support, but making sure weaning at an appropriate time and letting the lungs rest. Again, these cases I'm trying to engage into that there are norms. They all had some kind of contraindication towards it. However, we saw what it was driving. This is again along those morbid obesity cases, but 17-year-old male, again, 46 BMI, had a burns. We were called because platelets were 98 and WBC was 1.3 with blood cultures positive. Again, we have to factor into it. It's a young patient. We did cannulate. If I go through the regular indications or contraindications, there is very little flexibility, but this is where the multidisciplinary approach helps. And if you see discharge to rehab, ECMO support was total of 7 days. Early is better. Case number 4. Again, driving pressures and these high FiO2 needs. These are one of those things that we keep on mentioning. If somebody is at that point to start with, I don't think so it's going to get better. You're probably the vent strategy might harm more. I want to go to, because these are a similar case to it, but the interesting part about this is that when we cannulated this patient, right, and the patient arrived, so you don't know because they're very hesitant to, for example, hey, the patient desaturates. We can't get to the CT. We are very limited. So when we accepted the patient, within 6 hours, he was cannulated. And these were the images. He was on COVID isolation. If I think a lot of you might remember the JEDI. So now the patient is being transferred to CT ICU. However, it makes a stopover to the CT scan, and that's what we find out. Multiple areas of intraparenchymal hemorrhage at the level. And so again, do you stop? You can't, because honestly, what it needed is monitoring. Again, like I mentioned, the age, 37-year-old. Everything else was appropriately, compliance was getting better. We didn't stop. And ECMO support total days 10. No anticoagulation was given for 8 days due to the interparenchymal hemorrhage, and there was no complication associated with it. So that anticoagulation regime or time period, which was a taboo as well associated, at least for VV, is completely um, taken off. And then for VA, there is flexibility. It might be limited, but there is approximately 2 months of hospital course. This was truly a great save. It was a veteran, 38-year-old, who was transferred to us and had cellulitis, was treated with Bactrim, and then had these fever, chills, and then went downhill, had just 4-pack-year history, otherwise no other comorbid, just Bactrim treated. And then he was presented to with hypoxic respiratory failure, high flow, intubated on 516, and then it was because of his poor compliance, right IJVA ECMO support on 516, underwent tracheostomy. Now, from this, the lung transplant team at TGH for ECMO management and possible evaluation for lung transplant was called on 526, and subsequently he was transferred on 527. This this person had an extensive run and a course for complications. And I'm not going to go into this. Why? Because I have to probably give you this slide as a complication rather than small infarcts. Encephalopathy, weaning, sedation, drips. He was tons of Dilaudid, like that's like marination, 10 of Dilaudid or these kind of. Um, and he had start VATS done, left chest tubes, re-exploration, right thoracotomy, multiple like he was went for explorations, fungal infections. He was to be, I think, for a long run, he was on ECMO support. We were just waiting for his ID clearance from that fungal and for him to be conditioned and nutritionally optimized. This video, see, there's a lot of team members. That's a lot of equipment, a lot of team members, and a lot of collaboration that requires. Now, this is him. Underwent left renal and bilateral lung transplant on September 20th. ECMO decannulated. So simple, right? Without that equipment, it was so modified. Still, there's a lot of effort. But to bring him to that condition or to that nutritional status to do that is what ECMO kind of supported that bridge. And we are happy that we were able to help this veteran. This is my last case. So this is like very importantly, why? Because 18-year-old, extensive trauma injuries. This was probably my trickiest consult that probably went on for 4 or 5 days before we went into a conclusion and cannulated. So extensive trauma injuries, extensive hemorrhage, contusions, brain contusions, pulmonary contusions. He had right pneumothorax requiring right chest tube placement. His ICP bolt was placed, left frontal bolt, on the February 20th. He came to us on, I think, motor vehicle from bike on the 17th of February. Had bust of on EEG, severe diffuse cerebral dysfunction, and we were called on the 18th for hypoxemia and hypercapnia. We all know that with high ICP, you want those CO2s to be lower. And this was the conundrum going to with, so the team actually optimized appropriately, but it wasn't helping. This was the initial blood gas, 49, 93 PO2, but actually that was the problem, the PCO2 and the dynamics. This was the CT scan images. This was the last one case that I actually added on to. So you see these, and this is the bolt that I wanted to just point out. Now, ICP, these are the, and our teams are great. We collaborate great, but I wanted to just reflect on, these were the suggested goals and recommendations. ICP less than 22, cerebral perfusion pressures of 50 to 70, maintain normal carbia. If you recall, the PCO2s were 60. And over here, I'm sorry for the image quality. It's not that great, but I could tell you that the PCO2 was climbing to 65 and 42 because they could not ventilate of that extensive trauma. It was one thing or the other. This is when we were, again, we were following peripherally. And if you recall from the 17th, we were having daily discussions about, remember, this patient has a brain bleed. This patient has an Aspen collar in place. So ideally, you would want him either a right IJ crescent. Why? Because his left femoral groin had a clot. And there were too many dynamics that were playing. His cerebral perfusion pressures were more than 53 because we cannot lie him even flat. ICP was more than 17. We were not meeting those. And his pneumomediastinum and PF ratios continued to be worse. What we did, we just went, we were very open, neurosurgery, trauma, family, we had a multidisciplinary discussion with the patient, and we cannulated the patient. And I have to say that this patient was successfully decannulated on the 7th, and I just checked the chart, and just I wanted to mention that this picture from the 23rd, which was the cannulation time that we made, the X-ray doesn't look, well, sorry, this was the one, 24th February on the left side. This is the one where we made the decision to cannulate, and you do not see any ECMO cannulas over there. While on the 25th, now you see the ECMO cannula, but you can see that there was pneumomediastinum, and that's probably from the ventilator induced or this injury or from his trauma. But that was a discussion that needed to happen with the family, and we were very clear about that, hey, this is what it is. We cannot give bolus, order this. He has a brain bleed. We cannot lie him flat. He has limitations, but I have to say the age sometimes is the biggest factor that we have to take it into play, and reversibility. I want to focus on just these 2 points. That's reversible and reversible cause in acute phase. These are for me and our ECMO steering committee, or when we review the cases, or CTICU, our being the primary unit intensivist. This is what they're looking for to answer whether the patient is an appropriate candidate. This is, again, just a point about when ventilation strategy is hurting your oxygenation strategy or vice versa, think ECMO support. And again, I would like to emphasize, as much as I like the machine and I care and I'm passionate, the ECMO is not a cure, but it is a trial, just like a vent. It's a fancy vent. Just ECMO program. This is my final slide. Predicted growth. I have, and the team and the whole institution and organization as USF and TGH are really committed to grow the program and as a destination to decision versus recovery versus transplant, however we can help the patient. Again, we have rolled out a RShock call to streamline the processes and to have everyone have access to make these challenging cases discussed on a multi or a transdisciplinary manner in order to provide care. And then lastly, programmatic development. There are a lot of things that are happening, and I would get on board, but I would love to take the questions now. But patient selection and timely referral is the greatest determinant of outcomes.
Thank you, Dr. Qureshi. That's fantastic, and I really appreciate
the rushing, but I just wanted to make sure that I reflect on the hard work that USF and TGH faculty does and care for all these patients.
Absolutely. And again, Dr. Mosley, our chair, who is at a senior retreat today, wanted to extend his thanks to you and the entire team. And again, we had over 100 folks that at some point were on this meeting. Note that a lot of folks take this in conference rooms or in workrooms together. So Dr. Mosley really wanted to emphasize how much our department Grand Rounds does for the culture and the ethos of our department. This was an outstanding presentation, a very difficult topic to bring forward and generate excitement and interest because it's so complex. You did an outstanding job. I love the cases, especially the outcomes with the patients. The video was incredible to show a lot of the real time that goes into these patients, and the importance of mobility of these patients and the village that it takes to do this. Again, thank you for all your great work and really reflective of the entire ECMO ECLS team. Congratulations again on that gold level designation, showing the really great partnership between USF and TGH. We have time for questions. Dr. Qureshi is not only a incredible speaker, but he had the talk right at that 50 minutes. So great job. And let's see if we have any questions for Dr. Qureshi on this very important topic. Jen, did you have any questions on the chat?
Nothing in chat, but Dr. Qureshi left his cell phone number in there if anybody wants to reach out.
Oh, very good. Very good. Sounds like you impressed everybody, Dr. Qureshi. I have no questions. So you went over the material in incredible fashion.
Thank you. Thank you, Dr. Lizama. I do appreciate the kind words, and I hope if anybody has questions,